This is Blood and Cancer, the official podcast of MD Edge Hematology Oncology. I am the voice of MD Edge Podcast's Nick Andrews. And welcome to episode 71 of Blood and Cancer. I am Nick Andrews. This is the official podcast of MD Edge Hematology Oncology, where we bring you interviews and different conversations about the best in clinical heme onc. And I'm joined this week, as I always am, by Dr. David Henry. And Dr. Henry, I heard that we had to find an innovative way to take a group photo at your hospital this year.
Well, it's we're recording this as we're mid-May, toward the latter half of May. And the academic years, as our listeners know, tend to end toward June. And it's a sudden, I kind of love it and hate it every year. It's a sudden change. We say goodbye to the oldsters and welcome the youngsters. And we take a group photo. Well, not allowed because of COVID. So, of course, in this high-tech era, we've learned all how to do electronic communication and Zoom all the time. Our photographer said, everybody come over, and one by one, we'll stay socially apart and then step outside in front of the hospital one at a time. And he would take a picture, and he's going to put it all together and look like it was a group.
It's amazing what you can do with technologies these days, and everyone is out here making do. I know that iHeartRadio, one of the bigger podcasting platforms out there, you can listen to Blood and Cancer on iHeartRadio, just dropped their commencement series, which is a bunch of speeches from people like Eli Manning and John Legend, and so we're all trying to make do. Yeah, very cool stuff. So big interview this week because there is something involved with COVID, a complication that a lot of people kind of hadn't predicted when this first started back in January and February, and that has to do with coagulation. So we welcome Dr. Adam Cuker once again to Blood and Cancer. We're talking about coagulation in COVID patients and different treatments and indications and heparin and a bunch of different stuff.
So a few months ago, we talked to Dr. Cuker about the evaluation of the bleeding patient, and I think this was before this epidemic hit. And he's our lead clotter, so to speak, at the University of Pennsylvania. Really talented clinician scientist, understanding and explaining to us coagulation. And as our listeners know, there's something going on with this virus that is unusually severe with clotting. We discuss whether it's particular endothelial damage that the lining of your small vessels doesn't like what's happening and starts to clot, or stasis if you have heart failure, or if you're immobilized in the ICU. Is it organ damage? But whatever, it leads to extraordinary clotting, the end result of D-dimer. So he goes into how you want to measure D-dimer. Is the higher, the worse, and more potential for clotting. And then we get into, well, if we are still understanding it, how can we treat or prevent it? So he makes a case for it. He's helping write the up-to-date. In fact, he's written it twice in a month, he said, on the up-to-date website of what's happening with COVID and coagulation, so that you'll hear him suggest prevention dose, usual prevention dose for any admitted COVID patient. If they're a little sicker, then maybe half dose therapeutic, and certainly consider for those patients who are ICU level therapeutic dose to prevent severe coagulation, venous thromboembolism, DVT, unless there's a bleeding issue to avoid, consider full anticoagulation. So really good, thoughtful interview.
Yeah, and it's obviously one of the more important ones we've done with regard to COVID, just because this coagulation thing has been such an unforeseen aspect. The virus is it's so impressive in its ability to spread and find new hosts, but it's got a lot of weird curveballs. There are dermatologic issues, and now this coagulation thing is kind of out of left field. And so this is one of the more important COVID topics that we've done. So there are extensive show notes available wherever notes are found. They include research and outlines to the topics discussed, and they are authored by one of our favorite authors of the show notes, and that's Dr. Emily Breyer, of course.
At Pennsylvania Hospital, one of our rising stars among all of our rising stars, Pennsylvania Hospital, and the show notes will be posted on our website, mdh.com/hematology-oncology for this interview or previous interviews. And of course, I couldn't resist. I'm a senior clinician, and they want me to stay away from the hospital. So to get my picture taken today, I actually go to the hospital. And before I could leave, I couldn't stand it. I took the elevator up to the 7th floor, and I want to give a shout out to our nurses and doctors and our oncology unit on the 7th floor for all they've done. Well, I've been across the street seeing outpatients. They've been working hard inpatients. So we really appreciate and thank you for all you do for being in the front lines.
Yeah, absolutely. Thanks so much. So many of the people bearing the brunt of the outbreak are nurses and other staff, and it's such an important time when we do these podcasts and try to educate as many people as we possibly can, and also connect in a human way. We give a big shout out to those people on the front lines, no question about it. So I have a quick announcement to make, and that is that MDH has 3 podcasts: dermatology podcast, a hemonc podcast, and a psychiatry podcast. It has been recently determined that because one of our psychiatry host is an expert in psycho-oncology and the relationship between diagnosis and being a survivor, we are going to have a conversation between Dr. Henry and Dr. Lorenzo Norris about psychiatry and oncology. And we're going to try to do crossovers with dermatology and blood and cancer as well. And that's all very exciting stuff to look forward to this summer.
So you can all listen to me break down, and as a psychiatrist tears me apart with all my personal problems and taking care of patients and life. And never mind. It'll be all about other things.
Let's go back to the time when we became a Villanova fan. Let's start there.
Let's go back to Villanova. Please bring back sports.
Bring back sports. It's on the way. That's the rumor, but we'll be here through it all. So coming up after this, Dr. Henry's conversation with Dr. Adam Cuker about coagulation in COVID-19. Dr. Henry, I hope you're staying safe and get a good night's sleep, and we'll see you next week.
Same to you, Nick. Thanks so much. See you next week. Welcome to this podcast. I'm your host, Dr. David Henry, coming to you from Pennsylvania Hospital in Philadelphia, and you're listening to the podcast Blood and Cancer, which airs each week Thursday mornings on iTunes or wherever you get your podcasts from, and also on our journal, electronic journal called mdedge.com/hematology-oncology. And continue with our theme of what's hot in the COVID era as we all try and take care of patients and adjust to the almost daily changed information. I'm delighted today to be interviewing Dr. Adam Cuker, who's a colleague of mine at the University of Pennsylvania, where he's associate professor and director of the Penn Center for Comprehensive Care of Hemophilia and Thrombosis and Hemostasis. And Adam, welcome to this podcast once again.
Thanks for having me, David.
Well, you're very welcome. And as we've all learned, I'm a hematologist oncologist, and most of our listeners are in that area. But as generalists, hospitalists, and certainly infectious disease doctors take care of these patients, we've learned that clotting has been a surprise issue. So I thought we'd cover a few things and just begin with the top of VTE, venous thromboembolism, DIC, disseminated intravascular coagulation. This is happening more than we would have expected in sick patients. So maybe your take on what's happening and maybe a bit about why we think that might be happening in these patients more than usual.
Sure. Thanks, David. So it's so interesting. The first few months where publications were being reported out of China, January, February, even into March, there was really very little written about thrombotic risk. And then we started to have a lot of patients in the United States. And I was hearing, particularly from the ICU docs, boy, we're seeing a lot of blood clots, a lot of DVT, a lot of PE, a lot of patients clotting off their CVVH filter. But it was all sort of anecdotal at that point. And then in early April, we started to have the first case series published. And those case series were reporting primarily on patients in the intensive care unit and showing truly remarkably high rates of venous thromboembolism. To summarize, probably half a dozen studies from various centers around the world, the rates of VTE were running in the 25 to 30% range, despite the use of prophylactic intensity anticoagulation. And, that may even be an underestimate because, of course, as our listeners know, some of these patients are so sick that they're not able to get imaging. Maybe they're not stable enough to go to the CT scanner, or there's a concern about exposing the text to potentially the virus. And so some of these patients may have blood clots that have been going undiagnosed. So that's what we first noticed, with very high rates of venous thromboembolism. Then some additional reports started to come out, autopsy reports of unusual findings like microvascular thrombosis, particularly in the lungs, almost suggestive of a thrombotic microangiopathy type picture. And I'm sure many of your listeners now have heard reports in the lay press about not ICU patients, not even hospitalized patients, but non-hospitalized, previously healthy outpatients.
Young people, active people, yeah.
Exactly, presenting with stroke. I've had several patients present with this new disease called COVID toe syndrome, where there are sort of ischemic toes as part of the presentation, and that appears to have potentially a thromboembolic etiology. So lots of different thrombotic manifestations, and at least in the ICU, occurring with much greater frequency than we're used to seeing in critically ill patients.
So I've seen a slide, well, two thoughts come to mind. One, HIT syndrome, I'll come back to that thought, and a slide you showed recently at an update of us here at Penn on Virchow's Triad. So can you take us back to medical school and remind us what Virchow's Triad is and how that may be happening here to promote more clotting than usual in these patients?
Sure. So the big question, of course, is what's the mechanism? Why are these patients so prothrombotic? And the short answer is that we don't know, but we're learning more every day. But whenever I think about mechanism of thrombosis, I always like to go back to Virchow's Triad. And as you will recall from the recesses of your mind in medical school, Virchow was a German pathologist in the 1800s who postulated that thrombosis occurs because of one of three reasons: circulatory stasis, some intrinsic hypercoagulable state in the blood, and or endothelial injury. And when I apply these to COVID patients, I think that there is at least a potential for all three to be operating. So we can start with circulatory stasis. Patients who are sick with COVID, especially those in the ICU, are immobilized, right? Many of these patients are on sedatives and paralytics and in the prone position, barely moving, and even some pretty sick patients at home are bedbound for a few weeks with this condition. So immobilization may be playing a role. Then there's the hypercoagulable state. So we know that this is a real hyperinflammatory condition, at least in the critically ill patients. Very high levels of factor VIII, of fibrinogen, circulating procoagulant microparticles, something called neutrophil extracellular traps, which may be part of the link between inflammation and thrombosis. And so these patients do appear to have an intrinsic hypercoagulable state, very possibly related to the inflammatory cytokine storm that occurs in the critically ill patients. The third piece is the endothelial injury, and this is where I think it's very interesting, and there may be some unique aspects to COVID. So we know that endothelial cells have ACE2 on their surface, and ACE2 is the portal by which the virus infects cells. And there's some evidence, although it is not conclusive at this point, that the virus is able to directly invade and infect endothelial cells, resulting in endothelial activation and endothelial injury. And so what this means is that the endothelial cells release things like factor VIII and von Willebrand factor into the circulation, which are certainly prothrombotic. And the sick patients have very, very high levels of these proteins in their plasma. And then the endothelial cells may become inflamed, which promotes basically adhesion of platelets and may underlie the thrombosis in this condition. So a lot more to learn, but I have a feeling that all three aspects of Virchow's Triad are at play.
So the reason I mentioned HIT a moment ago is it occurred to me as I learned about heparin-induced thrombocytopenia syndrome years ago, we can't just stop the heparin. Something else goes on to make these patients for the next 30 days, especially the ensuing 7 days, hypercoagulable, probably because of the antibody that you made against the triad of the heparin and the platelet and the antibody. So do you think maybe we're seeing some patients who we're hearing are asymptomatic and get infected and, of course, develop some antibody? That may be operative here. Are we still learning about that? Is it somehow similar to the antibody you might generate?
Yeah, I don't know if it's antibody-mediated the way HIT is, but I do think that there are certainly parallels. So, I mean, first of all, both are profoundly hypercoagulable prothrombotic states. Both seem to be associated with both venous and arterial thrombosis. And when we talk about treatment, there's an interesting parallel as well. Up until a couple months ago, it was the only disease that I could think of where even when a patient doesn't have a clot, the risk of clotting is so high that we treat the patient with therapeutic intensity anticoagulation. So if a patient has what's called isolated HIP, if they're diagnosed with HIP but they have no clinically apparent thrombosis, as you say, we not only treat them by stopping heparin, but we treat them with a therapeutic intensity non-heparin anticoagulant to reduce their clotting risk. I can't think of any other situation in medicine where we use therapeutic intensity anticoagulation to prevent a clot rather than to treat one. Now there's COVID, and there's lots of discussion and controversy about whether we should be using higher doses of anticoagulation and even therapeutic intensity anticoagulation for primary prevention of clots in these patients. Yeah,
because in these both types of hypercoagulable patients, the HIT or the COVID sick patient, I get my head around it by saying to trainees, the platelet count's 70, how could they clot? I say, well, that's because you just checked their vein in their arm. Those platelets are all sticking in little clumps in the toes, as you mentioned. So the COVID toes or COVID fingers are clotting out there. So maybe that's the parallel. The platelets are very busy elsewhere, being consumed in a hypercoagulable state. And, of course, we have to address that and treat it. And the D-dimer, you mentioned, of course, the DIC type phenomenon. The D-dimer is sky high. Is it higher than you've seen in memory and DIC type syndromes? What's up with that?
Yeah, the critically ill patients in particular have very high D-dimers. And what's clear is that a couple interesting things to note about these D-dimers. First, they seem to track with illness severity and prognosis. So the higher your D-dimer, the more likely you are to not survive the disease. Mm-hmm. And then secondly, this isn't the sort of classic picture of overt DIC that we're used to. With overt DIC, the elevated D-dimers are accompanied by low fibrinogen, by thrombocytopenia through to accelerated consumption of clotting factors and platelets. But that's not true in COVID coagulopathy. In COVID coagulopathy, despite the very high D-dimers, patients tend to have normal or even you often elevated fibrinogen levels. And significant thrombocytopenia is uncommon, except in the sort of very sick end-stage patients who may evolve to overt DIC. But there are many patients who are in the ICU quite ill, but not at that point, who have markedly elevated D-dimers, levels that we are not used to seeing in other contexts, and yet their platelet count and fibrinogen are fine.
So, it brings to mind in the oncology space, pancreas cancer, metastatic mucin-secreting adenocarcinoma, Trousseau's type syndrome. You won't see acute DIC parameters, but you see fibrinogens might be high, platelets may be a little low, and high, although I don't think this high, D-dimers. So maybe it's a slowly evolving DIC as opposed to the acute syndrome.
Yeah, I think you make a good point. In some ways, it bears resemblance to a chronic DIC picture. But there are some differences as well too. I think the D-dimer is so much more elevated than we're used to seeing in our chronic DIC patients, for example.
Yeah, so I thought next I would mention two references you're familiar with. I know our listeners want to get to therapy, which we're going to get to with this anticoagulants and prevention of these VTEs. But one of the earlier trials you sent me, the CLOCK, KLOK, the CLOCK trial in thrombosis research, tipping us off to saying, watch out, there's the title of the article, Incidence of Thrombotic Complications in Critically Ill ICU Patients with COVID-19. So can you mention one of the first calls to arms of that trial and what they were seeing?
Yeah, absolutely. So the CLOCK study was an observational study of, I think, 3 intensive care units in the Netherlands, and basically reporting rates of diagnosed venous thromboembolism in the patients in their ICUs. And this came out in early April, and it showed a very high rate of venous thromboembolism despite the use of prophylactic intensity anticoagulation. There's some challenges to the analysis because patients were followed for different lengths of time, but essentially the authors, using their statistical approaches, estimated a risk, an incidence of 31% of clinically apparent venous thromboembolism in their patients, which is much higher than we're used to seeing in ICU patients. Usually the rate of thrombosis in ICU patients receiving prophylactic anticoagulation is in the 8 to 10% range. So this was about 3 times higher than we're used to seeing. And the reason why this study was so important is it was sort of the first of its kind. As I mentioned, those first few months, the reports coming out of China really didn't mention thrombosis at all. Yeah. And then we started hearing anecdotes from our ICU colleagues about thrombosis. And I have to say, at the beginning, I was kind of a skeptic. And I said, how much of a problem is this really, if in all of those publications from China, we never heard about it? Mm-hmm. And then the first real data that we got was this paper from the Netherlands, which basically vindicated what the ICU docs were telling us they were seeing with their own eyes. And subsequently, there's been a number of other centers that have published their experiences, and those experiences have been largely in line with the data from the Netherlands. So now I'm a believer too.
Well, that makes 2 of us and many of us. And one more reference before therapy. We're recording this on May 13. This just came out last week, May 6, in the Journal of the American College of Cardiology, where they had comment on in-hospital mortality was in the 20s, 22.5, who received anticoagulation, and 22.8 in those who didn't. But maybe if you can comment, the longer the mortality was better in those who got the anticoagulation.
Yes. So this was a large study out of Mount Sinai, where, of course, it's right in New York City. They've had a large number of COVID patients that they've treated in their hospital. And what the authors tried to do is just take a look back and split the patients into 2 groups, patients who received anticoagulation and those who didn't, and see whether there were any differences in outcomes. And what they found is that, first, when they looked at their overall study population, there was no difference in mortality between those who did or did not receive anticoagulation. But then when they looked at the subgroup of patients who were on mechanical ventilation, they found that treatment with anticoagulation was associated with significantly reduced mortality compared to those who were not treated with anticoagulation. Now, these data are suggestive that anticoagulation may be important in these patients, but I think we have to interpret this study with a major grain of salt. I mean, this is an observational study. These patients were not randomized to anticoagulation, so there are probably really important differences between the 2 groups, what we call confounders, and they were not able to adjust their analysis for all of the potential confounders that could have affected the results. They also, in the study, didn't describe the dose or intensity of anticoagulation, which I found to be an important limitation, because I think there's almost consensus at this point that we should be putting all of these patients, at least those without a contraindication, on some dose of anticoagulation when they're in the hospital. The question is, should we just use standard prophylactic intensity? Should we use intermediate intensity? Or should we even use therapeutic intensity to try to prevent these clots?
Well, let's go there to therapy. And I think last time we spoke, you were involved with getting the up-to-date chapter up-to-date on that wonderful living resource online with COVID and coagulation. So that is done or still in process as you prepare it?
Yeah, so there is a chapter on COVID-19 hypercoagulability on up-to-date, where it's actually already in its 2nd edition because the evidence is being published so fast and furious in this area that we're finding that we need to update the chapter every week or 2.
My goodness.
So it's up. But it will probably need to be updated again soon. Things become out of date very quickly in this field.
Well, you can only imagine 100 years ago with the flu epidemic and textbooks and articles way late to help people know what's going on and what to do. Now it's up to date. It's changing every couple of weeks. That's amazing. Well, let's go on to therapy, which you've really helped guide us with in your research and accumulation of the facts and the data and guidance. So I think if I just say from top line, you can fill in the blanks. If someone is not so sick, it's usual prophylaxis. If they're sicker, maybe half-dose prophylaxis. And if they're sick, and especially as they get to ICU, it's full therapeutic intensity. Is that what you're recommending?
I think to some degree. So we certainly would agree that in hospitalized patients who are stable, we, at least in our institution, are recommending just standard intensity prophylaxis. If somebody is in the ICU, as long as they are not considered to be an increased bleeding risk, we are recommending either intermediate or therapeutic intensity anticoagulation. We're sort of leaving that decision to the discretion of the providers. The reason why we're not being more prescriptive is because there is just not evidence yet to tell us what the right thing to do is. And of course, by increasing the dose of anticoagulation, we're going to expose patients to increased bleeding risk. And so we want that to be done, only with caution and great thoughtfulness.
Is there any hint that the D-dimer might go down and help guide us that we're getting the right effect, or that's not correlated?
It has been hypothesized, but we don't yet have evidence. There are institutions, David, where the institutional guidelines suggest using the D-dimer as a means of deciding who should get standard prophylactic intensity anticoagulation and who should get higher dose anticoagulation. We decided not to do that here at Penn because while we think the D-dimer may be part of what's important, there isn't any evidence yet to support using a D-dimer to guide dosing of anticoagulation. So we really decided to base it on how sick the patient is. So if the patient is stable on the floor, standard prophylaxis. If the patient is in the ICU or they're on the floor, but they meet certain criteria for being sick, like high oxygen requirement or organ failure, then we recommend thinking about stepping up to intermediate or even therapeutic intensity anticoagulation.
Okay. Well, I think we've certainly covered a lot of ground. I'm just trying to think of anything else. I've got you. Anything else you want to say to our listeners about coagulation, hypercoagulability in this area? Research is fast and furious, and I thank you for all you've done and are doing. Anything else to comment on?
Thanks. Yeah, no, this has been great. I guess there are two other populations that I've been getting a lot of questions about. So we talked about patients in the ICU. We talked about hospitalized patients on the floor. What about patients who are discharged from the hospital?
Of course, yeah.
Should we be using post-discharge prophylaxis? And the second population is, what about non-hospitalized patients? Is there any role for anticoagulation, prophylactic anticoagulation in that group of patients? And so, very briefly, we unfortunately at this point have zero evidence on the incidence of thrombosis in these two groups of patients. And there are studies that are ongoing that will answer this question, but at this point, we have zero evidence. So we have to base our decision-making on intuition and extrapolating from non-COVID patients. And so we know that acutely ill hospitalized medical patients have an increased risk of thrombosis when they are discharged from the hospital, and that risk lasts for about as much as 90 days, but it's probably highest in the first month. And that was the basis for clinical trials and ultimately FDA approval of rivaroxaban, 10 milligrams a day, or betrixaban for post-discharge prophylaxis in acutely ill medical patients who meet certain criteria.
Is that for 30 days, Adam? How long?
Yeah, so approximately 30 days. The durations of time differed a little bit with the different clinical trials, but they center around 30 days.
Okay.
And so based on those clinical trials, those FDA approvals, and our concern about thrombotic risk in these COVID patients beyond discharge, what we are doing at our institution is considering the use of prophylactic intensity anticoagulation for about 30 days after discharge. And the treatment that we're typically using is rivaroxaban 10 milligrams a day because that is an FDA-approved regimen for post-discharge prophylaxis. Again, we desperately need evidence on the baseline incidence of thrombosis in these patients and whether we're doing the right thing in terms of reducing that risk without causing an undue number of bleeds. The second group where we have zero evidence is what do we do about non-hospitalized COVID patients? Yeah. These are, as you say, the young adults who are presenting with stroke, who had no previous risk factors, should we be giving all these patients antithrombotic therapy to try to prevent these complications? And I think at this point, I would say no. We have, again, no evidence about incidence in this group. It may be that it's a very small number of cases that is getting a very large
A lot of attention. Yeah.
Exactly. And so I don't think it's wise to treat potentially millions of patients around the world based on a small number of cases. But that said, I might consider prophylactic intensity anticoagulation, something like rivaroxaban 10 milligrams a day, for an outpatient with COVID who has significant risk factors, like a previous history of venous thromboembolism or maybe recent major surgery. Just things to think about. This is a question I've been getting asked a lot about lately, so I wanted to mention it here.
Well, I think we've covered everything, and I can't thank you enough for all you've said and all you're doing to clarify this as we go forward. So I want to thank you again and remind our listeners we've been listening to Dr. Adam Cuker, and that's spelled Cuker, who's Associate Professor of Medicine at the Hospital University of Pennsylvania here at Penn, where he is the Director of the Comprehensive Hemophilia and Thrombosis Center. And to remind you, there are show notes for this, bullet points of what Adam has just said today on our electronic journal webpage, mdedge.com/hematology-oncology. And those show notes are done by our very busy and wonderful, and we praise them, House David Pennsylvania Hospital. So we thank you all for listening. And Adam, thanks again for taking the time to do this today.
Thank you, David. Great to talk to you. Bye-bye.
Bye-bye.
And that's a wrap on episode 71 of Blood and Cancer. Blood and Cancer is produced and hosted by the Editor-in-Chief of MDH Hematology Oncology, Dr. David Henry. It's produced by MDH Hematology Oncology Editor, Jennifer Smith. Dr. David Henry's guest today was Dr. Adam Cuker. All MDH podcasts are produced by the Editor-in-Chief of MDH and Medscape, Dr. Ivan Aransky, as well as MDH Executive Editors Mary Ellen Schneider and Kathy Skarbeck, MDH Multimedia Editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio editor, audio engineer, and the voice of this podcast, Nick Andrews. You're listening to Blood and Cancer, produced by MDH.